Welcome. In this session, we are going to take up malignant intraocular tumors, some of which we have already discussed. Intraocular malignant tumors can be classified as neuroectodermal malignancies and uveal malignancies. Among the malignant neuroectodermal tumors, we have already discussed retinoblastoma, meduloepithelioma, and adenocarcinoma of retinal pigment epithelium. Retinal metastasis and leukemic involvement of the retina we will be discussing in this session when we take up their counterparts in the uvea. Among the malignant uveal tumors, we have uveal melanomas, which we have already discussed in previous sessions, as well as metastasis, secondaries, lymphomas, and leukemias. We must note that primary vitreoretinal lymphoma is not an uveal malignancy, but we are going to discuss it along with the other lymphomas which are uveal in nature. Intraocular metastasis from a distant primary is the most common intraocular tumor in adults when we consider benign as well as malignant intraocular tumors and primary, secondary as well as metastatic intraocular tumors. The most common route of ocular involvement is hematogenous, and uveal tissue with its multiple arterial supply is most commonly involved, with choroid being involved much more frequently than iris or ciliary body. Retina with its single arterial supply is rarely involved alone. Intraocular metastasis can be multifocal as well as bilateral. Most common primaries to metastasize to the eye are carcinomas, mostly adenocarcinomas, and in a descending order, the most common sites of primaries causing uveal metastasis are breast, lungs, an unknown primary site, and the gastrointestinal tract. Breast is the most common site of primary in females, and lungs the most common site of primary in males. Cutaneous melanoma infrequently metastasize to the eye, but when they do, they have a predilection for the retina and the metastatic tumor masses to be pigmented. Ocular metastasis is usually detected after detection of the primary, and the interval between diagnosis of the primary cancer and the diagnosis of the ocular metastasis can be many years. However, in 30% of ocular metastasis, the ocular metastasis is detected prior to the diagnosis of the primary cancer, and this occurs particularly with lung cancer, in which 50% of ocular metastases are detected in patients who are not yet known to have lung cancer. Anterior segment metastasis to the iris and the ciliary body appears as a white to pink lesion as seen here in this photograph, and associated features which can also be present include iridocyclitis, iris neovascularization, secondary glaucoma, hyphema, pseudohypopyon as seen here in this photograph, and dilated epibulbar vessels overlying the tumor. Patient with a choroidal metastasis may be asymptomatic or complain of painless visual loss. 20% of choroidal metastasis can be multifocal or bilateral, and the choroidal metastatic mass usually appears as a homogeneous white to grey ill-defined and minimally elevated mass with a placoid or lumpy bumpy contour. The tumor typically lacks intralesional blood vessels because it is a rapidly growing tumor and blood vessels do not find enough time to grow within the tumor, and so intratumoral subretinal or vitreous hemorrhage is uncommon. Unlike choroidal melanoma, mushroom configuration is rarely seen, and as we have mentioned, metastasis from cutaneous melanomas can be pigmented. Associated features include serous retinal detachment, often extensive and out of proportion to the size of the lesion, uveitis following necrosis of a rapidly progressive tumor, and clumping of pigment in the retinal pigment epithelium overlying the tumor, which is also called leopard spotting. And this particularly occurs in slow-growing metastasis such as metastasis from breast cancer, and also following systemic chemotherapy given for the primary tumor, causing partial regression of the ocular metastasis. Metastasis to the optic nerve presents with abrupt onset and progressive loss of vision and or visual field defect. Clinically, we find discohesive white to pale yellow infiltrates on the optic disc. We will see a photograph of leukemic infiltrates on the optic disc later in this session, and we can also appreciate optic nervate edema. Metastasis to the retina most commonly occurs from cutaneous melanoma, as we have discussed, and in this situation the metastatic tumor usually appears as brown spherules. Otherwise, a retinal metastasis usually appears as a white, smudgy perivascular lesion resembling either cotton wool spots, vasculitis, or retinitis. And retinal metastasis can have associated intraretinal hemorrhage, exudation, and vitreous seeding. Ultrasound biomicroscopy helps in estimating the size and extent of an anterior segment metastasis, and ultrasonography is useful for posterior segment metastasis. On ultrasonography, a choroidal metastasis appears as an ill-defined, broad-based lobular or nodular mass lesion with an irregular and a high internal reflectivity, as seen here in this photograph. Fundus fluorescent angiography can help in defining the margins of the lesion, but is less useful in differentiating primary choroidal tumor from choroidal metastasis. And as we have mentioned, because of its rapid growth, choroidal metastases do not develop an intratumoral vascular supply, and so on angiography they do not demonstrate either early choroidal vascular filling or double circulation. Double circulation means simultaneous visualization of dye within the retinal circulation as well as within the intratumoral circulation. OCT, especially the enhanced depth imaging mode of OCT, usually shows lumpy bumpy elevation below the retina. Magnetic resonance imaging is indicated for suspected optic nerve metastasis to define the extent of optic nerve involvement, and cytology of vitreous tap can be useful in diagnosing a retinal metastasis. Systemic evaluation is important, particularly when there is no history of a primary cancer. An imaging of breast, chest, abdomen and pelvis is recommended to locate the primary tumor. Imaging of the brain is also indicated because of a high chance of a coexisting brain metastasis along with the intraocular metastasis. Fine needle aspiration biopsy of a suspected ocular metastasis is indicated when the diagnosis cannot be established otherwise. And on the FNAB specimen, the metastasis is often found to be less differentiated than the primary, and when the primary site is not known, immunohistochemistry on the FNAB specimen may help in narrowing the list of possible primaries. And the diagnostic results on the FNAB specimen may indicate need for change of therapy even when the primary lesion is known. Aims of treatment for ocular metastasis is preservation of vision as far as possible and palliation of pain. Indications for treatment of ocular metastasis include loss of vision, pain, proptosis and strabismus. In patients with widespread metastasis involving multiple organs in the body, systemic chemotherapy is given alone when ocular metastasis responds to the systemic chemotherapy. Otherwise, additional local radiotherapy is administered for the ocular metastasis. In patients with only ocular metastasis, local radiotherapy alone may suffice, and enucleation is indicated when there is intractable pain. Average life expectancy after detection of ocular metastasis is typically less than 1 year. 5-year survival rate following detection of ocular metastasis in breast cancer is said to be 25%, and 1-year survival rate following ocular metastasis detection in lung cancer patients is said to be 50%. Ocular secondaries occur when malignant tumors of tissues adjacent to the globe invade the globe, and they are much less frequent than ocular metastasis because sclera is an effective barrier against secondary invasion of the globe by extraocular tumors. Ocular secondaries occur most commonly from conjunctival squamous cell carcinoma, and usually the aggressive variants of this tumor such as mucoepidermoid, adenoid and spindle cell carcinomas invade the globe, and that too only after recurrences following several attempts at local excision. Less commonly, conjunctival melanomas, eyelid basal cell carcinomas and malignant lymphomas of the orbit and paranasal sinuses can invade the globe. Treatment options for ocular secondaries include resection, radiotherapy, and enucleation. Lymphomas involving the eye are mostly non-Hodgkin's B-cell lymphoma and are rarely of the T-cell type, and they can be classified into primary vitreoretinal lymphoma, which is also known as primary intraocular lymphoma, primary uveal lymphoma, primary adnexal lymphoma, and secondary ocular involvement from systemic lymphoma. Primary adnexal lymphoma we have discussed in the oculoplasty section, and we will be discussing the remaining three in this session. Primary ocular lymphoma is considered to occur independent of systemic disease. Primary vitreoretinal lymphoma is also called primary intraocular lymphoma, and it is the most aggressive type of ocular lymphoma and is usually a diffuse large B-cell lymphoma histopathologically. Primary vitreoretinal lymphoma is usually associated with primary central nervous system lymphoma, and patients with primary central nervous system lymphoma may present with behavioral changes, seizures, and paresis. Primary vitreoretinal lymphoma is considered to be a subset of primary central nervous system lymphoma. PVRL can occur prior to, concurrent with, or following PCNSL. 25% of PCNSL patients later develop PVRL, whereas 60% of PVRL patients later develop PCNSL. In this entity, dissemination of the lymphoma outside CNS is very rare. PVRL may present unilaterally but ultimately becomes bilateral in the majority of patients. HIV patients have a higher incidence of PVRL, and in this situation, the patients are usually younger and have associated Epstein-Barr virus infection. PVRL PCNSL usually affects elderly patients in 6 to 7 decades of life, and patients with PVRL usually present with decreased vision and floaters. PVRL is characterized by two major clinical features, either or both of which may be present in one patient. These two characteristic clinical features of PVRL are vitritis and sub-RP infiltrates. Vitritis and vitreous haze can be significant in PVRL patients, obscuring retinal details, as we see here in these two photographs of a patient presenting with PVRL in the left eye having dense vitreous haze obscuring retinal details. Thus, PVRL can resemble posterior uveitis and belongs to the syndromes considered as uveitis masquerades. In contrast to posterior uveitis, the vitreous cells of PVRL are fewer, larger, and whiter, and often arranged along vitreous fibrils in a string of pearls appearance, and these vitreous fibrils with the adhered vitreous cells may align into sheets. The sub-RPE infiltrates appear as elevated geographic and creamy yellow lesions, and there can be subretinal infiltrates as well, which appear as ill-defined yellowish white lesions. And the sub-RPE as well as subretinal infiltrates may change appearance and location over time. We see these white sub-RPE lesions in both these photographs. Associated features of PVRL include perivascular infiltrates and vascular occlusion, as well as RPE pigment clumping over subretinal infiltrates. There can be minimal to absent cells in the anterior chamber. In PVRL, characteristically, uveal involvement is rare, which distinguishes it from primary uveal lymphoma, which has a much better prognosis. PVRL typically shows transient and or incomplete response with systemic corticosteroids. So typically these patients are initially labeled as posterior uveitis patients responding to systemic corticosteroids and recurring during tapering or following withdrawal of steroids, and this happens for multiple cycles before a diagnosis of PVRL is entertained. When PVRL is suspected, a contrast MRI imaging of the central nervous system is recommended if PCNSL is not already diagnosed. A lumbar puncture with CSF cytology should be done when CNS imaging is positive or if there are new onset neurological symptoms and signs. A diagnostic vitrectomy is very useful to establish a diagnosis of PVRL and is usually done when CNS imaging and or CSF cytology is negative. And during diagnostic vitrectomy, vitreous, and when appropriate, subretinal aspirates are collected. It is very important to ensure that the laboratory is capable of handling and diagnosing from a small quantity of aspirate. Even then, the results can be false negative because of low concentrations of malignant lymphoma cells in the aspirate, and these malignant lymphoma cells have a tendency to autolyse. So vitreous aspirates in suspected PVRL patients need rapid transportation and testing, and multiple diagnostic vitrectomies are often required before we can arrive at the diagnosis. Corticosteroids, which decrease the count of the lymphoma cells, should be stopped for a few weeks before diagnostic vitrectomy is performed. The tests which can be done in the diagnostic vitrectomy aspirate include cytology, in which we find atypical large pleomorphic lymphocytic cells with high nucleocytoplasmic ratio, scanty cytoplasm, hyperchromatic nuclei with multiple nucleoli, and typically they are admixed with smaller, more mature lymphocytic cells. Often, the malignant lymphoid cells are necrotic and admixed with intact, mature, smaller lymphocytic cells. Even then, we can arrive at a diagnosis of PVRL. Other tests which can be done with the diagnostic vitrectomy aspirate includes immunohistochemistry with flow cytometry to study cell surface markers to determine monoclonality of the aspirate, and we can determine light chain restriction in the form of expression of either lambda light chains or kappa light chains in the majority of cells in the aspirate, and in the form of expression of either CD19, CD20 or CD22 in the majority of cells in the aspirate. Genetic studies with PCR or FISH can help us to identify genetic rearrangements and mutations, such as mutations in MYD88 gene in PVRL. And in PVRL, the ratio of interleukin 10 to interleukin 6 is typically more than 1. Interleukin 6 secretion predominates in inflammatory lesions, and interleukin 10 secretion predominates in neoplastic lesions. Other diagnostic tests which may help us in management of PVRL patients both initially and during follow-up include fundus fluorescent angiography and indocyanin green angiography, which show hypofluorescence and hypocyanescence respectively in the region of the sub-RPE infiltrates. Later on, following resolution of the sub-RPE infiltrates with development of RPE atrophy, these tests will show patchy hyperfluorescence in the form of leopard spotting. Fundus autofluorescence shows patchy hyperautofluorescence from areas of active sub-RPE infiltrates, which show hypofluorescence on fluorescein angiography. And when the lesions resolve with RPE atrophy, we will find patchy hypoautofluorescence on fundus autofluorescence. Ultrasound B scan may show discrete nodular and placoid lesions, subretinal fluid, and vitreous syneresis with increased reflectivity from the vitreous cavity. OCT shows the subretinal and sub-RPE infiltrates as amorphous nodules, as seen here in this photograph. The intraocular disease or PVRL is treated with intravitreal chemotherapy with methotrexate or rituximab, or with low-dose EBRT if there is no response to intravitreal chemotherapy. And the central nervous system lymphoma is treated with intravenous methotrexate with intrathecal methotrexate and whole brain irradiation. Intravenous methotrexate alone is not sufficient for treatment of PVRL because of poor intraocular penetration of methotrexate, and so methotrexate for PVRL should be given by intravitreal injection. The major cause of death of PVRL patients is PCNSL, and without treatment, median survival of these patients is less than 4 months. However, with treatment, median survival of PVRL patients without PCNSL is 58 months, but after they develop PCNSL, the survival drops to less than 40 months. So overall, patients with PVRL and or PCNSL have an extremely poor prognosis. In contrast, primary uveal lymphoma is a low-grade lymphoma of the extranodal marginal zone B cell or MALT category, having a much better prognosis as compared to primary vitreoretinal lymphoma. Previously, they were called reactive lymphoid hyperplasia because of their indolent clinical course. They also typically occur later in life primarily in the sixth decade, and can occur in any part of the uveal tract. Involvement of retina and vitreous is uncommon, unlike primary vitreoretinal lymphoma, and also they are typically unilateral, unlike primary vitreoretinal lymphoma. Although they are termed primary uveal lymphoma, one-third of these patients ultimately develop systemic non-Hodgkin's lymphoma. So in contrast to primary vitreoretinal lymphomas, primary uveal lymphomas are low-grade lymphomas with a much better prognosis, occur in the uveal tract instead of the retina and the vitreous, and are typically unilateral. Primary uveal lymphoma patients usually present with insidious onset and gradually progressing loss of vision. On examination, we find multifocal choroidal lesions which appear creamy yellow in color. So these are choroidal in location and not sub-RPE as in primary vitreoretinal lymphoma. And the lesions in primary uveal lymphoma appear similar to the infiltrates in birdshot chorioretinopathy. Associated features of primary uveal lymphoma include subretinal fluid, glaucoma, diffuse uveal thickening, epibulbar salmon-colored infiltrates which are firmly attached to the sclera, in contrast to the infiltrates of subconjunctival lymphoma which are mobile over the sclera, and posterior extrascleral extension of the lymphomatous infiltrates can cause proptosis. B-scan ultrasonography is the diagnostic modality of choice in primary uveal lymphoma, which shows a diffuse smooth to nodular choroidal thickening which is homogeneous with low echogenicity. Subretinal fluid may also be detected in the B-scan, but what is characteristic and pathognomonic of primary uveal lymphoma are presence of extrascleral crescentic areas of low echogenicity representing extrascleral extension of the tumor. Biopsy from an easily approachable adnexal site is preferred, but if no such site is present, fine needle aspiration biopsy from thickened uvea needs to be done. And biopsy typically shows small mature lymphocytes with plasma cells. Imaging of the central nervous system, chest, abdomen and pelvis is recommended to detect presence of associated systemic lymphoma. Other tests which can be done include indocyanine green angiography, which shows hypocyanescent patches in the areas of choroidal infiltration, and optical coherence tomography, particularly the enhanced depth imaging mode, will show placoid or diffuse irregular hyperreflectivity of the inner choroid. Subretinal fluid, if present, will be detected by OCT. Primary uveal lymphoma is treated with low-dose radiotherapy, and prognosis for survival is excellent, unlike in primary vitreoretinal lymphoma as we have mentioned. Secondary ocular lymphoma is the involvement of the eye from systemic lymphoma, usually by hematogenous spread, and most patients with secondary ocular lymphoma have a known initial diagnosis of systemic lymphoma. Clinical features include infiltration of any portion of the uveal tract which appear as creamy white subretinal lesions, and there can also be associated features resembling uveitis such as vitritis, iritis with pseudohypopyon, retinal vasculitis and retinitis. Typically, patients with primary uveal lymphoma do not have these features. Associated adnexal lymphoma in eyelids, conjunctiva and orbit can also be present. For diagnosis, biopsy from the most accessible site with adequate tissue is preferred, and usually biopsy shows high-grade diffuse large B-cell lymphoma. Treatment of secondary ocular lymphoma involves systemic chemotherapy, orbital radiotherapy and/or bone marrow transplantation, and prognosis of secondary involvement of the eye from systemic lymphoma is poor, with average survival after ocular diagnosis being less than 3 years. Eyes are commonly involved in leukemia, usually through a hematogenous route. Patients may be asymptomatic or complain of loss of vision. Clinically, retina is the most commonly involved structure, and retina can be involved in leukemia either due to secondary effects of anemia, thrombocytopenia and hyperviscosity, or due to direct infiltration of the retina by leukemic cells, or due to infections of the retina from immunocompromise. The most common manifestation of retinal involvement in leukemia are hemorrhages, Both retinal and subhighlight hemorrhages, specifically white-centered hemorrhages called pseudorod spots, secondary to thrombocytopenia, anemia, and hyperviscosity. As seen here in these photographs, we see retinal hemorrhages as well as white-centered hemorrhages. Other manifestations secondary to thrombocytopenia, anemia, and hyperviscosity are dilatation and tortuosity of retinal veins, venous occlusion, macular edema and hard exudates, retinal microaneurysms, cotton wool spots, retinal neovascularization, and vitreous hemorrhage. Less commonly, we can find retinal infiltration with leukemic cells which appear as yellowish-white infiltrates in the retina and subretinal space in a perivascular distribution. Rarely, there can be retinal or subretinal abscesses from secondary infection, and they can be commonly confused with the leukemic retinal infiltrates and may require diagnostic vitrectomy to arrive at the correct diagnosis. Histologically, choroid is the most commonly involved ocular site in leukemia, but choroidal involvement with leukemia is difficult to detect clinically. Ultrasound shows diffuse thickening of the choroid with or without serous retinal detachment, and it is known that uveal tissue acts as a sanctuary site for leukemic cells, giving rise to recurrence of leukemia. Optic nerve involvement with leukemia presents with rapid and severe vision loss, and clinically we will find leukemic cell infiltration in and around the optic nerve as seen here in this photograph. Leukemic infiltration of the optic nerve is a medical emergency requiring urgent radiotherapy to preserve vision. In the vitreous cavity, there can be secondary infection in leukemic patients leading to endophthalmitis, and in the anterior segment, iris involvement with leukemia can lead to diffuse thickening of the iris with loss of iris crypts along with nodular thickenings as well, and associated pseudohypopyon and hyphema as seen here in this photograph. Angle involvement leads to raised intraocular pressure, and we have previously discussed orbital involvement with leukemia, particularly granulocytic sarcoma, also known as scleroma, in the oculoplasty section. Diagnostic procedures which may be required in a patient suspected of having ocular involvement with leukemia include diagnostic vitrectomy, systemic imaging, lumbar puncture, and bone marrow biopsy. Both the retinal leukemic infiltrates and systemic leukemia are treated with systemic chemotherapy. But if the ocular response to systemic chemotherapy is inadequate, local radiotherapy is also administered. And as we have mentioned, radiotherapy is mandatory in optic nerve involvement with leukemia. To summarize, uveal metastasis is the most common intraocular tumor in adults and usually spreads to the eye by the hematogenous route. In descending order of frequency, the most common primary sites for uveal metastasis are breast, lungs, unknown primary site, and gastrointestinal tract. Breast cancer is the most common primary site for uveal metastasis in females, and ocular metastasis in breast cancer usually occurs months to years following diagnosis of the primary. Whereas lung cancer, which is the most common primary site for uveal metastasis in males, ocular metastasis may be diagnosed before diagnosis of the primary. Iris metastasis may appear as iris mass with or without pseudohypopyon and or hyphema. Choroidal metastasis appears as ill-defined placoid lesions which on ultrasound show irregular and high internal reflectivity. Primary ocular lymphoma is of two types, primary vitreoretinal lymphoma and primary uveal lymphoma. Primary vitreoretinal lymphoma is an aggressive high-grade non-Hodgkin's lymphoma usually associated with primary central nervous system lymphoma. Primary vitreoretinal lymphoma usually presents with vitreous cells and sub-RPE infiltrates, and primary vitreoretinal lymphoma with primary CNS lymphoma has a very poor survival rate. Primary uveal lymphoma is an indolent low-grade non-Hodgkin's lymphoma presenting with uveal infiltrates, and compared to primary vitreoretinal lymphoma, primary uveal lymphoma has a very good survival rate. Ocular involvement in leukemia usually presents with retinal hemorrhages, often white-centered retinal hemorrhages, but may also have anterior segment involvement in the form of pseudohypopyon and optic nerve involvement. Thank you for listening.